Hello and welcome everyone. Thank you for joining today's session on your favorite channel, Cancer Reach. Cancer Reach is an initiative by our very own tumor defeater, Dr. Krishnamani, to spread awareness about cancer and help patients and caregivers access the right treatment at the right time. Welcome to today's live session on tumor markers in cancer. Now, when we hear the term tumor marker, it often raises questions. Is it a test for cancer? Can it help in early diagnosis of a tumor? Who should get tested? To answer all your questions today, we are joined by a doctor who will help us understand what tumor markers are, when they are useful, when they are not, and how patients and caregivers can make sense of the tests for these specific tumor markers without any fear or misunderstanding. Without much further ado, let me introduce our doctor to you. Dr. Krishnamani has been associated with AOI hospitals in Hyderabad since the past decade. He has extensive expertise in managing a wide range of cancers, including both solid tumors and hematological malignancies. He is well versed in delivering advanced treatments such as biological therapy, immunotherapy, and is skilled in managing oncological emergencies. He has been actively involved in academic contributions and professional development, participated in numerous seminars and meetings, attended various workshops to enhance his skills as a medical oncologist. Welcome to you, sir.
Hello and welcome to Cancer Reach. Cancer Reach is an initiative to spread awareness about cancer, and as you said, today let's discuss about tumor markers.
So, sir, what exactly are tumor markers and where are they present in the body?
So, when we listen to the word tumor markers, it means we immediately assume that tumor and there is something which is associated with tumor. Though it is partly true, it is not the whole truth. So, to keep things very simple, these are certain commonly done blood tests. Okay, so they are not done in the tissue, they are done in the blood. The blood sample is taken, these uh, tests are done, and these tests are commonly elevated in cancers. But please understand, they are not diagnostic of cancer. They can be seen in non-cancer conditions also. They are not specific for one type of cancer. They can be seen in other cancers also.
So, are they specific only for cancer or can they be diagnostic for other infections or other conditions in the body?
Other non-cancerous conditions also can have elevated tumor marker. Cancers can have normal tumor marker. So if we have to just summarize, it's a blood test associated with cancers, but can be seen in normal patients also, can be seen in non-cancerous conditions also, not specific for a particular cancer. The same tumor marker can be elevated in another cancer also, and can be normal in a patient with cancer. So just because tumor marker is elevated doesn't mean you have cancer. And just because tumor marker is normal and you have a biopsy proof of cancer doesn't mean you don't have cancer. So tumor marker is a surrogate. You will just utilize it in your diagnosis. It is not the principal. So very rarely or only in one disease or two diseases you will take tumor marker as diagnostic. Otherwise, the message which should go out is a biopsy is mandatory in most cancers to prove a diagnosis. Tumor markers are only additional tests or ancillary tests which help in or aid for our diagnosis.
Can you explain some commonly used tumor markers in cancers?
So you have a tumor marker called PSA, prostate specific antigen, which is seen in prostatic cancer. CA125, which is seen in ovarian cancer. CEA, which is seen in colon cancers. CA19.9, which is seen in pancreatic or bile duct cancers. And then there are other tumor markers like LDH, which is non-specific, which is seen in lymphomas or germ cell tumors. Beta HCG, which is seen in testicular or ovarian tumors. Then alpha fetoprotein, which is raised in testicular tumors or liver cancers. So Multiple sets of tumor markers are there. It depends on what you are uh, diagnosing. So if you are going to think on the lines of liver cancer, you are not going to do CA125. You will do alpha fetoprotein. If you are planning or if you think like it's a pancreatic cancer, you will do a CA19.9.
Okay. So, is it right if I say that tumor markers can help us detect cancer earlier than the symptoms also set in a patient?
No, that is not right. So what you are trying to say is, can you use it as a screening test? So screening means what? In a normal population, you do a test to detect a disease early. Now you and me are there. We don't have disease, but we want to know if we have disease. You want to do one blood test, like do a CEA or 125 in both of us, and want to prove if we have cancer. No. When you are asymptomatic, when you're a normal person, tumor markers are not helpful for screening. Only when you suspect cancer are you going to use tumor markers to aid in the diagnosis.
Okay. Can they be used to monitor treatment response, or if the patient can have or can have a cancer recurrence?
Yeah. So now, how are you going to do that? So now, suppose I'll give you an example. Uh, a lady who's 50 years who comes with a lump in the abdomen. She says, I'm eating little, but I feel full. She says, repeatedly, the doctor they do a scan. They say there is an ovarian mass and there is water in her abdomen, ascites. They tap the fluid, they put a needle and remove the fluid. So you are suspecting ovarian cancer. Why? Because of her symptoms, because of a large ovarian mass. What will you do? You will send a CA125. CA125 is normal, less than 30. Normal is 35 or 30. So does it mean you don't have ovarian cancer? Is the scan lying to you? Is the patient not having symptoms? So 30% of ovarian cancers can still have normal CA125. So you have to do a biopsy. So what is the role of CA125 here? It is not screening. The patient already had symptoms. And also it is not helping you in the diagnosis because it is normal. So your diagnosis is biopsy. Now imagine another lady, same scenario. CA125 is 5,000. Will you say 100% you have ovarian cancer without a biopsy? Because ovarian cancers can be many types: endometrioid, clear cell, serous. You need to know that. That will be known only on a biopsy. What will you say? You have an ovarian mass, you have ascites, you have raised CA125 more than 5,000. You could have ovarian cancer. Most likely it is ovarian cancer, but I have to prove with the biopsy. It comes as ovarian cancer. You start treating this patient. Now CA125 after 2 months of treatment comes down to 150. What does it mean? 5,000 became 150. Symptom wise also patient is better. Water has subsided. You need not tap this patient every week. So what will you say? We are not removing your fluid. There is no fluid that has completely disappeared. Your symptoms are better. CA125 has come down. So you are responding to chemo. You finish the treatment. After 2 years, you're constantly taking the CA125 every 3 months. Patient is fine. After 2 years, CA125 again becomes 500. Then you will suspect recurrence. So it is not useful for screening. It is useful for diagnosis, but not in everybody. It helps you to monitor treatment if it was elevated initially. In the first patient, when it is normal, what is the use? If it is 30, even after 9 cycles, it will be 30 only. You cannot, only if it is elevated and coming down, you will say disease is coming down. So it helps you in monitoring treatment. It aids in the diagnosis, not useful in screening, and helpful in recurrence in those in whom it was initially elevated.
Is it possible that these tumor markers can give a false positive or a false negative clinical scenario?
I told you just now, 30% of ovarian cancers can have normal CA125. Or the CA125 can be elevated in pregnancy, menstruation, adenomyosis, endometriosis. These are all non-cancerous conditions. CEA is elevated in colon cancer, but not all colon cancers. In left-sided, it is more elevated. Right colon, it may be normal. It may be elevated in pancreas cancer, gastric cancer, esophagus cancer. That doesn't mean if anybody has a CEA, high CEA and a stomach cancer, you will not say, no, 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 CEA is seen only in colon cancer. Your stomach cancer diagnosis is wrong. So CEA can be elevated in colon cancer. It can be elevated in non-cancer conditions. It can be seen in other cancers also. Same with CA 125. So it is not tumor specific. Now PSA, prostate specific antigen. It is specific to prostate, not specific to prostate cancer. Because PSA, if the prostate has infection, prostatitis, the PSA will go up. If the prostate increases in size because of age, BPH we call benign prostate hypertrophy. Elderly men find difficulty in voiding urine. They have a large prostate. That's a common thing. Most men above 70 will have, above 65 will have. There also PSA may be elevated. Infection PSA is elevated. Cancer also PSA is elevated. And one type of prostate cancer called small cell prostate, PSA is normal. So PSA can be elevated in prostate cancer, in BPH, in prostatitis, but it can be normal in another prostate cancer called small cell prostate. So bottom line, they are elevated in cancer, they are elevated in non-cancer conditions, they're elevated in different cancers, so they're not cancer specific. They can be normal in cancers. They are not useful for screening. They are aiding in diagnosis. If elevated and falling down, it's an indication of treatment response. If going up, it means the treatment is not working. And if it decreases and comes back again, it means there is probably a recurrence.
So, in your clinical practice, sir, you would prefer to use tumor markers in combination with biopsy and with imaging, and you will not rely solely on tumor markers as a diagnostic tool.
First, you will always see a patient and its symptoms, his or her symptoms and signs. Is the patient getting better, patient getting worse? Second, you will do the scans. Is the scan getting better, scan getting worse? Third, you will need a biopsy diagnosis. Fourth, tumor markers will aid in your diagnosis.
Is there any genetic predisposition to these tumor markers? Like, for example, if the father has it, then should the son also get the tumor marker testing
No,
done?
no. This is not a genetically related thing, right?
Okay. And are there any risks or limitations of depending solely on tumor markers for cancer diagnosis?
Now, as I said, you have a ovarian mass, but normal tumor marker. So that's a limitation. It is not useful. You have a raised alpha fetoprotein. It could be elevated in hepatocellular carcinoma. It could be elevated in hepatoblastoma. It could be elevated in gastric cancers. It could be elevated in germ cell tumors. So you should use your clinical acumen or your brain to choose the right tumor marker. So as my teacher taught us, how do you diagnose cancer, he used to say, or what are the tests you do for a new cancer patient? He always used to say, I will do a test to confirm my diagnosis with a biopsy and immunohistochemistry and then molecular typing. I will do test which to stage the disease if it is cancer, like a CT, like an ultrasound, like a PET CT. So I will do a test to confirm my diagnosis, which is always biopsy. Once confirmed, I will do a test to stage the disease, which is scans. I will do tests which support my diagnosis, which is your tumor markers. They only support. Finally, I will do tests to look at the general well-being of a patient, like your blood picture, kidney function test, liver function test, heart echo, pulmonary function test, etc. These tell me how my heart, lung, liver, brain are all working. So this is a classic teaching.
Are there any ongoing developments in the field of tumor markers?
Not that I know of for certain, but these have been there for quite some time, and people have tried to use tumor markers as a screening tool. For example, PSA has been proposed as a screening tool for high risk men above the age of 40. Suppose you have many people in your house with prostate cancer, or somebody has BRCA positive prostate cancer, they say get a PSA after you're 40 every year. So these are some of the additional things which have been added up.
And In your clinical experience, like how often do tumor markers change your treatment decision or change the course of your treatment that you're giving to the patient?
No, as I told you, you would look at the patient's symptoms. You would look how bad or good the scans are. Tumor markers are only an additional test. In fact, let me tell you, in ovarian cancer, there's a classical teaching. You have treated a patient. Okay. Many now you've done surgery, you've done chemo. The patient is fine. They come every 3 months. You check them, they're doing well. The CA-125 is going up. 50 has become 75. Will you immediately rush into a PET scan? No. You will say, yes, the tumor marker is going up, but you are asymptomatic. I will not even scan you, maybe. So the patient's symptoms are more important, not the tumor marker. But suppose 50 becomes 5,000, you will tell the patient, see, there is a rapid rise within a very short period of time. Now you are not having symptoms, but this rapid rise, maybe you may have symptoms in future. So let us scan you once. Who knows what's there inside? But if 50 becomes 52, 28 becomes 31, no, it has increased. So chalo, we'll scan you. No. So tumor markers should always be taken with a pinch of salt. Use your common sense. Look at the patient's symptoms. If required, do an imaging to see how bad or good the scan is.
Okay, sir. So now on to bursting a few myths. So the first one is that the tumor markers can detect cancer early in all the cases.
No, they are normal in most cancers also.
A high tumor marker level always means cancer.
No, but could be cancer. If it is cancer, high tumor marker means a bad prognosis. High tumor marker means probably this patient is not going to do well if it is cancer. That also means probably a large tumor burden. If you have large amount of tumor only, you'll probably have a high tumor marker value.
Tumor markers can tell exactly where the cancer is located.
No way. That only a scan will tell you.
If tumor marker levels go up during treatment, it means that the cancer is getting worse.
Probably, most likely. If you're treating for ovarian or colorectal cancer, your CEA, CA-125 goes up, maybe the disease is coming back or it is increasing, it's not responding to your treatment. But it could also increase with a diarrhea, a colitis, an infection. So, and how much it increases also matters, and the symptoms of the patient are more important.
Sir, your summary for today's informative session for our audience.
Simple test can be done literally everywhere in the country today, not at all expensive, detects a variety of cancers. Like I told you, there are multiple tumor markers, CEA for colon, CA-125 for ovary, AFP for liver, beta HCG for germ cell tumor, PSA for prostate, but they are not cancer specific. They can be elevated in normal patients also with other conditions. They can be elevated with other cancers also. They can be normal in cancers also. Never use it in isolation. Use it always with the imaging, and biopsy is mandatory.
Thank you for this informative session, sir. Sir, we have heard about the second opinion campaign, which is being run by you. Is it also for those people who are in remote locations who are unable to travel to this city for consultation?
So yes, on Cancer Reach, we are running a second opinion campaign. It's free. The aim here is we want, or the aim here is to reach out to patients who reach out to us and give them sound oncological treatment plan, irrespective of whether they come here or they're somewhere else. We usually try to respond as soon as possible, maybe within a day or two. Uh, Questions are posted on YouTube. We have a WhatsApp number, which is a dedicated number where patients do send their reports and we reply to them. And this is purely with the aim that patients who want or who seek medical attention can reach out to people like us.
I think it's a very good initiative, sir. Thank you for taking the time out and explaining us about tumor markers and cancer. It was a very informative session, and we hope to see you again next.